I'm going to turn it over in a moment to the interim director of the party Center for the Study of the Longer Range Future, Jorge Heine, whom I don't know how many of you know Professor Heine, but I wanted to take this opportunity because this is the first event that he is presiding over as the director of the center. This center is a jewel for the university and the party school. But it has been without a permanent director for a little bit. That was interrupted by the tragic passing of the previous director, and then COVID and some other issues. So I wanted to be here to inaugurate your inauguration and be able to say thank you for his leadership and willingness to take this over. Just a few words about Ambassador Heine. He was the first person I dined with when I came for my interview at party. I was sitting alone at lunch on my interview, and he graciously brought a box lunch and sat next to me, and we struck up a conversation, and that was instrumental in my wanting to come to have a colleague like you. He is the quintessential scholar practitioner. He's a lawyer by training and served as Chile's ambassador to India, to China, and to South Africa. He has written over 15 books. 17 books. That's right. Two just this past year. One on the rise of China and looking at China in the 21st century, and the other on the reemergence of a non-aligned movement among the global South, countries of the global South. His work is very richly historically informed, but it also very much looks forward. So to have you as the leader of a center that looks at the longer range future, I can't think of a more ideal person to take this role. So Ambassador Heine, thank you. Professor, Ambassador, Dr. Heine, thank you for your leadership, and thank you for welcoming our guests here this afternoon. Thank you all.
Thank you, Dean. Well, thank you, Dean, for joining us today, for your kind words, and for providing me with the opportunity to direct the center that, among other assets, has this conference room with a wonderful view of the River Charles. Most conference rooms tend to be somewhat claustrophobic. This one is not. So I hope we'll share many stimulating moments around this table. As you know, of course, better than I do, the center has been around for a quarter of a century. It planted the seeds for what is today the Paved School. The Paved Center was before the Paved School. So it is really a privilege to be here. It embodies the vision, the center that the remarkable philanthropist who was Fred Pardee had in his concern for understanding the future and what lies ahead for humanity. I don't need to tell you that we live in a rather troubled world. This is especially important to be able to look a bit ahead, and that is what we are up to. I've always been a rather future-oriented person, and this was a very special privilege to play a role in formulating some of those questions. As the Pardee School under new leadership enters a new phase in its growth and development, it is especially important to contribute to it from this particular corner of the school, and to do so in forward-looking mode, identifying opportunities to foster human progress. It is not very exciting to be starting this term's Global Health Politics Workshop with such a distinguished speaker as Professor Swidler from the University of California, Berkeley. I want to stand for myself, but I will forgive her for coming from the other side of the day. And she, of course, will be speaking about the part of the world with which not only our dean, but I myself feel a very close association with. I've spent 5 years in Southern Africa, and it is a part of the world that is very much a happening place, and this one in which I would like to learn more today. Before turning back the proceedings to the convener of this great series, Professor Joseph Harris, let me just leave one thought with you. At a time when the world is still reeling from the effects of the COVID-19 pandemic, the worst in a century, I cannot help but think how much remains to be done in matters of public health in my own part of the world, Latin America, in this regard. The U.S. Center for Disease Control, the fabled CDC, was established in 1946 and has played a key role in this country's public health in the past 7 decades. In 2005, Europe established its own CDC headquartered in Stockholm. And in 2016, Africa set up its own CDC, whose new building was recently inaugurated in Addis Ababa. Yet, in Latin America, according to some indicators, the region that was impacted the most by the COVID pandemic, with 30% of the world's deaths from it, and only 8% of the world's population, exposing us the many vulnerabilities of the regional health system. There's no CDC and no plans to establish them. Why is that so? And what can we do about it? Perhaps that can be a topic to be addressed at future Paved Center workshops. Professor Harris, over to you.
Thank you. All right, well, welcome to the event. We're very pleased to hear from Professor Ann Swidler, professor of the graduate school at UC Berkeley, and esteemed sociologist of culture, institutions, religion, and global health. Ann has asked me not to make a long introduction, so I'm going to leave it there. Please, Ann, take it away.
Okay, thank you very much for inviting me. Thank you, Ambassador, for welcoming me, and I'm just honored to be here in your first moments as director. So it's wonderful. I'm going to make a preliminary, I'm going to tell a story that I think will make me be able to skip through the first few slides very quickly, which is how I came to do this project. So I had worked in Malawi for many years, and in 2018, I was doing a religion project there with an undergraduate at Berkeley named Laura Goy, whose name you see on the slide. And we had a bunch of interviewers, one of whom was a woman I had known for many years. I'm going to call her Patuma, that is not her actual name. I had known that she was HIV positive forever, basically. She is a single parent. At that time, her daughter was 8. And we would sit there in these morning meetings. We met every morning to sort of go over what we had done the day before and that. And I noticed that she was kind of leaning her head back and not participating. And I would say, Patuma, come on, pay attention, let's get with the program. And then I noticed that she had an open sore on her face. And I asked her about it. And she said, well, her father had been sick and she was worried. And so she was picking at her skin. And then I noticed that her gait was uneven. And I thought, oh, this is HIV and started to affect the nervous system. I talked to a friend of hers, who's also a friend of mine, who's involved in the project. Everyone knows everyone's business. So just don't worry about confidentiality in this story. And I said, what's wrong? And he said, yes, she clearly has AIDS and it's going to kill her. So I talked to her and she said, yes, my family has told me that I need to make sure my young brother picks up my daughter at least once a week from school so that she gets to know him. So he was going to end up inheriting her daughter when she died. So I went to my friend he himself has been on antiretroviral drugs forever, and he's extremely sophisticated about everything, including the drugs. And I said, she needs 7 drugs. You've got to go, blah, blah, blah. So he takes her off to the hospital and they see the clinician or whatever, and they give her a salve for the sore in her face and vitamins. But they tell her that she can't get any new drugs because she needs more adherence counseling. And it turned out she had actually gone once before. So this is actually her second visit to the hospital, but they're adamant that they can't. So I went nuts. And I said, this friend, and I have another very good friend who's let's say she's a very impressive, imposing churchwoman that no one says no to. She's a frighteningly strong-willed person. And so I said, the two of you have to take her to the hospital again. I don't care what it takes. I am not coming back next year. And finding out that Patuma is dead and her daughter has gone to her young brother. I said, that cannot happen. I was just infuriated. So they go. She said they waited all day because if you even look impatient, they won't see you at all. So they waited very humbly, waited. Finally, they were seen. And between my knowledgeable friend and my morally imposing friend, they pleaded, berated, persuaded. It turned out that the high viral load tests she had gotten showed astronomical levels of virus, 28,000 copies per milliliter of blood. And they had come down very dramatically since she first started the adherence counts. So they thought it was that by their criteria, it was working, but that was actually a mixed up test, wasn't her test. And the guy actually said it couldn't come down that fast. So it must be mixed up sample. But if I give her second line drugs, I could get in trouble. So they worked it out that they paid him a $20 bribe to overcome his scruples about this. He put her on second line drugs. Her raging diarrhea disappeared within 24 hours. Her massive headaches, which were constant, unrelenting. By the time we left 2 weeks later, she told me they were only half as frequent. And the sores had already cleared up on her face. And she is alive and well to this day, and her daughter is fine. And so that is what led to this project. After that, I persuaded Laura Goy, who wanted to go to medical school. And if you look here, you will see that she is in medical school and she's now a second-year student and thriving, that she could come back the next year, get funding from the university and do a project on this. We contacted, and I think all this background is important for how things actually happened. I knew, I won't go into this, but I have a Dutch friend in Malawi who's a crazed dog fancier. Her dog was lost for months. And on the list of people who helped her find the dog was a woman named Mina Hosianapur, who's a physician with the University of North Carolina, big research and clinical center there on HIV. So I got in touch with Mina Hosianapur on the basis of basically nothing. And she agreed to have dinner with us in the capital. And she said, yes, this is a really serious problem. And we know a lot about it in large quantitative studies, but you're right that we don't have any qualitative research that tells us what's really happening on the ground. It would be useful. Then I knew Catherine Dovell, who's Kate is her name, from working with Susan Watkins, and Kate Dovell had at one point been a sort of protege, not a direct student of Susan's. And so it turned out Kate was already physically in Malawi working, running the research arm for something called Partners in Hope, which is not Partners in Health, which is funded basically via UCLA, although it has a Malawian director. And so she had some research people who could help us, and she could get us access to the clinics. And that's how, and we talked about it, and everybody's ideas are in here. So I don't know when it's published. I think Laura should be first author because she did most of the actual field work. So the problem on large scale is that although you might have think that the AIDS epidemic is over, nothing could be further from the truth. It is just about steady state from year to year. The number of people who are HIV positive remains incredibly high. And the UNAIDS strategy, which you probably know, is this 90-90-90. The idea is that 90% of the people who are HIV positive should be tested and know their status. 90% of them should be on antiretroviral drugs, and 90% of those should be virally suppressed. On paper, Malawi is quite close to those targets. It's not quite there, but it's close. The problem is that in Malawi, and I think in much of sub-Saharan Africa, antiretroviral drugs didn't really become widely available. They existed, there were experimental projects and whatnot until 2006 and afterwards. That's when the huge ramp up in ART became possible. And what is it now? We're in 2023. Lots and lots of people who got on meds are starting to have drug resistance. And there have been attempts to study this. We're not the only one, but for transmission, for the generation of new variants that are even more, for every possible thing, and for deaths and illnesses, this is a serious, serious problem. And it is not clear how they are going to deal with it, or how they will deal with it effectively. A little bracket here, which is after or just as we were doing this research, they were introducing a new drug, dolutegravir, which does not generate resistance as quickly. It's actually quite a good drug, but they don't give it to people who already have high viral load because they don't want to increase resistance by people who are already resistant, have virus that's resistant to 2 of the 3 medications in the existing combination drugs. They don't want to move them over to dolutegravir and generate more resistance to that drug. So, all right. And if you will, the research question here, for which I'm going to draw much larger conclusions, I hope, but is why don't those with high viral load get moved more easily, more quickly to second-line drugs? So just for anyone who doesn't know where Malawi is, it's poor. It's small geographically, but by African standards, it's actually a middle-sized country in the sense that it's got 20 million people. It's much more rural than most African countries. Okay. Oops. This is the graph that Mina Hosyanapur sent to me, and it shows what happens when they monitor viral loads. So you can kind of ignore the top 2 bars. That's how many people ever were tested and for how many people they got valid results, although the drop-off there is interesting. But of the 9,443 people who were found to have high viral load, meaning something is wrong. So whatever it is, they're not fully suppressed. They completed EAC, which is intensive adherence counseling. And I'm going to ask you to remember that one acronym with about a little over half those people. They collected a follow-up viral load sample from a fraction of those people. They got valid results from a fraction of those people. They got results that showed the people were still high viral load from a fraction of those people. And the number actually switched to a second-line drug was 834. So this is the quantitative picture of the problem we were trying to study qualitatively. Okay, I'm not going to talk about this at all. We did research in 4 clinics, interviewing. The most interesting thing we did that is unusual is we had a couple of very, very talented field workers who were Malawian, who hung around, overheard conversations, observed what was happening, chatted with people. And so we have a kind of observation that's usually not available in interviews. We also had access to interviewing clients because the organization we were with is officially mentoring 100 clinics in Malawi. And as part of that mentoring agreement, they can do research that improves the quality of their services. And that's built into the contract between them and the clinics and between the clinics and their clients. So the clients didn't have to talk to us, but we didn't have to get special human subjects to talk to the clients because they already have it. Okay, I want to first talk, the title of the talk is Paved with Good Intentions, and you know what the rest of that phrase is. And I have to make a disclaimer first, which is a lot of what I do and what people do who do qualitative studies of public health is find out what's wrong. And so it's, critical comments about what's wrong. I want to say global health overall is I think, the most fascinating field if you are interested in global governance, because it is the one area in which there is no global government. The WHO has zero authority to do basically anything. And yet they have managed through the informally coordinated cooperation of mega organizations, from the giant foundations to tiny NGOs to Gavi, the Global Vaccine Initiative, to this one and that one, to actually, the most impressive thing is they have inoculated basically everyone on the planet against polio. They have eradicated river blindness. They have gotten HIV drugs all over the world, actually into people's bodies. If you look at the successes on the large scale, they are massive. So this is coordinated. We have a discussion of this in our book, A Fraught Embrace, the romance and reality of AIDS altruism in Africa, but about how a lot of this coordination is through declaring various things an emergency. You declare an emergency, but it's because there is no consistent year in, year out global bureaucracy that could manage, we're going to worry about this. So the emergency focuses everybody's attention on the same thing, and you get a massive infusion of resources, and organizations at all levels start working on this thing that's now an emergency. And okay, I won't go on and on, but I just want to say, I don't want to deny here that the global health enterprise is both, because if there is ever going to be global governance, I think the global health arena provides a model of how it might work without having a central authority empowered to punish people, put them in jail, and so on and so forth. So I think it's interesting, not just because human health is so urgently important, but because it really is a distinctive, there's no term, it's the fact there's no real term for it. We actually don't understand how such coordinated, uncoordinated systems work. So that is, to me, the thing that makes global health so fascinating. And I don't think there's any other arena, including climate change and all these things, that has anything like the infrastructure of institutional capacities. Okay. I want to say, however, now I'm going to go to the critical comment, which is global mandates are part of these good intentions. They create unintended bad effects. And two of them had direct effects on the clinics we were studying. One is that the global know-it-alls, in their wisdom, had decided that it would be much better to require everyone to get a viral load test once a year rather than every other year, which had been the practice. And the second was that the tests became more sensitive. The actual test became better. So having a detectable viral load went from having a virus over 1,000 copies per milliliter to having over, I think the actual number was 20 or something like that. So both those things enormously increased the number of viral load tests that needed to be done, and there was no funding for new lab capacity. Now, it's not that these things would have been bad if there were suddenly a doubling of lab capacity, but already overwhelmed, not computerized. I was just talking to your dean, and there's no reliable electricity. Basically, all over Southern Africa now, ESCOM has cratered. It's the South African and provides LA. It's horrible. So power can be out for 12 hours every day. So the idea that you're going to solve this technologically, that is not going to happen. All right. So now to get to the field work we actually did, I want to give a sense of what this is really like on the ground. And I'll show you at the very end. I had one photograph. This is a register in which the high viral load tests that came back were recorded. And I don't know if you, by the way, you're not seeing anyone's name here. The guy, I had two photographs in one. He's got his arm across the names, but this one, he folded them back. So what you're seeing here are the places they live, not the names of the people. But what you're seeing is the hand recording of these tests in these books. And, each row is a client. The ART number is when the person got on antiretroviral drugs. So that second column after the place. And you can see that the numbers are hodgepodge. I mean, one person is just 171 or something like that, and somebody else is 690, and somebody else is 1433. So how are their files kept in order? Because the tests are coming back in no relationship to the ordering system they have for keeping track of who's who. They don't use an alphabetical system. They keep people by this number that is when they got on in that clinic, when they got on antiretroviral drugs or something. And then you see all the way across, and I would just say that as you go across the ledger, eventually an incredible number of these things are blank. That is, they never got the test back. They got the test mixed up. They lost the test. The person has to come back and be tested again. So this system for keeping track of who's who is just, and this is the hand you see is, and the knee you see right above the document. He's got this on his lap. This is the guy who actually was responsible for recording these things. Incredibly nice, hardworking, lovely I will say quite cute. Laura was enthralled. But, just that's what he does all day. He gets these results. He laboriously he has actually 3 different registers in which he has to enter them, but that's what he does. Okay. So, oops, I missed a slide. No, I didn't. Okay. So the thing they do instead of switching people to second-line drugs is counseling. And no matter what the person's situation, they insist that they need counseling. And what they need is IAC, intensive adherence counseling. And so we ended up focusing on why so much counseling and what was the counseling doing. So that is what most of our results are about. And I just want to say, switching people to second-line drugs is not actually more costly, because those of you who are American citizens, I don't know which of those you are, who pay American income tax, you personally are paying for the drugs. So that's the second-line drug. They do cost more in the sense they cost the system more, but they don't cost the clinic more. In some clinics, they're harder to access. So instead of keeping extra doses on hand for new clients who need to be enrolled as they do for the first-line drugs, in some clinics, they actually have to send for the second-line drugs to access them. But even that, they have vehicles and they can send for them and all that. We learned that there is enormous resistance to not doing counseling. And this has to do with the provider's understanding of their work. So first of all, these are the 4 arguments I'm going to make. Oh, except I forgot to put a number by the 4th one. The providers themselves really don't understand drug resistance. They just literally don't understand it. But more important, they see their work as a moral vocation, not just a job. This is not a matter of indifferent, corrupt. And there are such stories, but in the clinics we studied, these are highly committed people who believe in what they're doing. And that's the problem. They love counseling, and I'll try to describe why. And it correlates with a very important cultural pattern, which is the role of advising in a patron-client system where superiors and family system and guardians and patrons not only give financial support to those who depend on them, to their clients, but they give advice. It's a critical feature of the relationship. Okay, so first, providers themselves don't understand drug resistance. One problem is that the training of counselors is basically stopped. There was tons of training in counseling, and you could get a certificate in counseling and HIV counseling. I'm talking about VCT when it was called VCT. But as testing got incorporated into the regular healthcare system, and it was, you come in and you're sick, you get tested, you're pregnant, and you go to an antenatal clinic, you get tested. It became so routine, counseling really dropped out of favor as anything that was in anybody's interest. And they stopped creating new training, and they stopped creating new training manuals. So if you actually try to track down what's in the training manuals, it is lots of garbage, pardon me, from the era when there was no antiretroviral treatment. And that's when living positively was the only thing they could offer people who were HIV positive. And so it was lots of things about if you are careful with your diet and you eat. I still hear this. I heard this over and over, the 6 basic food groups. Now, it's very good if you're not starving and living on a diet of maize meal. It's very nice to eat the 6 basic food groups, but it actually has nothing to do with being high viral load. Nothing. Never have unprotected sex. We saw people devastated. One man we interviewed said, he said, I've tried so hard to get my viral load down and nothing has worked. So I sent my wife away. He said, I sent her back to her mother. And it's terrible. He's a 50-year-old man, never to have sex again. But if this is what I have to do to save my life, I thought, no, having unprotected sex, having it, that is not what gives you high viral load. What gives you high viral load is not taking the drugs. That will do it. taking them very irregularly, or having resistant virus. That's it. And all this other advice they're giving people, healthy fruits and vegetables, eat protein, avoid worry, imagine. Okay, so yeah, no, and so providers insist that they actually don't know why. So here's a society in which the experts are supposed to know more than the poor villagers, and they actually don't know why this person is high viral. So the person comes to you and says, but I tried, you told me to adhere better, I've been taking my drugs every day. So they take enormous pride in ferreting out the secrets people are not telling them. And once in a blue moon, that pays off. So we asked each person we interviewed on these staffs, what was your most gratifying experience and what are your most discouraging moments? And they said, oh, the woman who came and she was afraid to take her drugs. And it took me, many, many sessions before she acknowledged that her husband doesn't know she's HIV positive, so she wasn't taking her drugs. And we worked out a scheme that she would bring her husband in and we would test both of them as if we'd never seen her before. And sure enough, they were both HIV positive and we put them on drugs. And every time she comes, she's so grateful and she thanks me for her life. So that only has to happen once to convince you that that is the paradigmatic thing you're looking for. That's the high. The thing they seem to focus on obsessively is time. And this is just unbelievable. So this is a sort of combined typical conversation, not a specific quote from interviews, but the typical thing is, well, what time do you take your drugs every day? After someone insists they're being adherent. Well, I take them at dinner time. I take them at the same time every day. Well, but what time? Do you have a watch? And this villager says, no, they mostly, may not be literate and they certainly don't have a watch. Then how do you know the time? Well, I listen to Nzama Boma, which is news from the districts. It's a favorite program. You can find out what witchcraft is happening in every district. It's a kind of a call-in type program. And so I listen to Nzama Boma, but do you have a radio? No, but the neighbor has a radio. So I listen the same time every night. But does that radio have batteries or electricity? Batteries, what if the batteries run out? It's just, they are sure. And then when we actually interview them, we say, but how many, how long? And a lot of them thought if your drugs were 10 minutes late, that would account for high viral load. We talked to Mina Hosyanapur. She says that's ridiculous. Hours wouldn't make a difference. That's not, the drugs don't clear from your system exactly 24 hours after your last dose. That's just ridiculous. So, and providers' confusion leaves clients confused and often despondent. So here's the quote: I follow all the counseling that I was advised at the hospital. I also do not do plain sex. So I'm wondering why the viral load is high. Okay. This second part of this is that they really see this as a moral vocation and not a job. So religious meanings are pervasive. They're the idiom of everyday life in every respect. And they're taken very, very seriously by everyone. But these people especially really describe their jobs very, very often as a religious vocation. So here's this: it is not only for a salary, it is like a calling from heaven. We have to serve anyone, regardless of who the client is. We work as angels. What is more important is to preserve life. And how can you preserve life if you have no knowledge and passion for the client? And again, I'm going to skip the second quote because this is the enormous gratification from saving someone's life and feeling that you made a difference in having their gratitude. And the providers love counseling so much that everyone in the clinic does it. The data entry clerk, whose lap you saw there, he does it. The lab techs who take blood samples, they do it. The nurses do it. The clinicians do it. The orderlies do it. Everyone wants to do counseling, and they do tons of it. Now, partly they have a lot of clients, so they need extra help. So how do they learn to do it? We have not been trained in EAC, but according to the way we work, we know that when we have counseled a client, this way it will help. But also another clinician told me what to do because at that time he was busy. So I followed what the clinician had tipped me on, how to conduct EAC. So, et cetera. I won't read the whole quote, but the point is, not only is training largely non-existent, but even the few people who are trained. And let me say, sometimes this leads to really interesting, really good. I had interviewed a nurse who was English speaking, so that was helpful. I mean, she knew English. And so there was a break in the day because the power went out and nobody had anything to do. So she sought me out and we sat and chatted for another long while. And she said, oh, yes, well, I tell clients you should do a lot of foreplay because if the woman is well lubricated, that will reduce HIV transmission because she won't be dry and she won't create micro tears and this. And I thought, well, that's smart. Where did you learn that? And she said, oh, I just figured it out. And I thought, well, that should be in any training. But that was, in other words, they are literally sort of by the seat of their pants, using their own moral knowledge, in her case, fairly sophisticated understanding of HIV transmission. And I'm going to believe in a very positive way, her own experience to generate counseling that made sense to her. So you really are in a situation where it's the workers on the ground who do not want to abandon counseling. And so they're not really interested in second-line drugs. There's no romance in handing somebody a better tablet. And I will say only the clinician and the nurses can prescribe such a thing, whereas the data entry clerk who might be doing the counseling can't. But I hope I've got the slides in the right order. Yeah, maybe I'll back up and make this point. It's on another slide, but I think it goes better here. The Ministry of Health was aware of some of these issues and it issued a mandate. So when you're put on intensive adherence counseling, it also means you no longer get a 3-month drug supply. You get a 1-month drug supply, which forces you to return to the clinic 3 times as often. And that's in order to force you to get more EAC and to get a new viral load test. So these people, it's extremely burdensome and difficult. And so the Ministry of Health decreed that people who needed intensive adherence counseling should still be given a 3-month prescription. And the clinicians just won't do it. They won't do it at all. Some of them claim they never heard of this. Others said, oh, no, I know, but they're wrong. These people need EAC every month, and if they don't come back, they lose, and blah, blah, blah. And so, I mean, the Ministry of Health had a new directive, and it just was ignored because they believe that EAC is the thing that works, and they need to do more of it. So the fourth thing is this traditional role of advising. And again, I don't want to take the time to read a long quote if you can read it a little bit. But what you see is this enormous desire to have good advice to give. And I will say in my own experience of, in essence, becoming a patron and employing someone, even if they work very, very hard for the quite modest amount of money you pay them, they understand this as a patron-client tie. So you understand it as an employment contract. But from their point of view, it's a patron-client tie. So I had the experience of coming back. One of my interviewers had been, she was working for me, but she also had been offered a job by a British group that I had basically put in touch with her. And then a third person who is at the University of Wisconsin had suddenly shown up and she was hiring. And I said, wow, I don't know what you're going to do. You've got it. And she smiled and she said, oh, I'm not worried at all. She said, I'm not going to decide, you are. And that, I mean, she regards me as a patron and she was going to have me advise her and make the decision for her. So she did not have to worry. All right. So I will say that this moral commitment to counseling and a very demeaning view of clients can go together because in the traditional system, the more educated person who's higher status looks down on these villagers, believes they're incompetent, believes they don't know what they're doing. So I can see that people like at this facility where you're seeing most people who are coming from the villages, the rural areas, and you know how people from the rural area, as they act, you can counsel them, you can do one-on-one counseling and they will not understand you. No, they have their own way of doing things. They like polygamy. So such people, it is difficult to maintain them on the treatment. and I'll turn to you, although all of us from immigrant families know this, stories about the ignorance of your forebears and their backwardness of the villagers and embarrassment over your immigrant family and their embarrassment over the impoverished villages they came from and foolish villager stories are pervasive. This is true everywhere where people are trying to become more modern. They are trying to leave behind the village ways that they are embarrassed about. At the same time, they're sentimentalizing them. And this is one of the points we make in the Fraud Embrace, that the brokers who are telling, supposedly expert global health people what's really going on the ground have their own very deep ambivalence about villagers whom they don't really know any because they don't live there and probably only visited their grandmothers as children. And they sentimentalize and they also disparage. All right, I'll leave it at that. So the consequences for clients are very difficult. This is where I talk about the switch from 3-month to 1-month drug supply. And it both leaves clients extremely confused and upset about why they have high viral load. They kept asking our interviewers to explain to them why they have, and of course the interviewers were, unable to help them. And they thought they should. So we actually had to keep them from advising people when they themselves had no idea why. And they often describe this switch as punishment. Yes, I took it as punishment, and I told the doctor that I live far and I need transport every time I come here. When they were being queued up, they would put a sticker on it's called a MasterCard. It's the file. Well, it's like a huge 1-page health record in a clear folder. Again, very large format. They would put a sticker on if you needed a high viral load test. People would try to sneak and peel the stickers off so they wouldn't have to take such a test, because being found to be high viral load got you into this nightmare of monthly drug supply, never being able to get off, eons of EAC. That'd be a good title for a paper, actually, eons of EAC. And so providers understood this, and sometimes they used it for punishment. So here we have a poster at one clinic warned that if clients forgot to bring their pill bottles back so they could do a pill count, they would be put on monthly drug supply as basically a way of forcing them to remember their pill bottles and so forth. So it's a little like if you forget your ticket at the parking lot, you have to pay for 24 hours, kind of like that. So here is just one more photograph that gives you a little bit of a sense of what the logistics are. This is why the lines are so long. The wait in these queues is endless, sometimes 2 or 3 hours, sitting, waiting to be seen. And this is a woman trying to sort these patient records. She's trying to pull them out of shelving with huge binders full of things with numbers on them, find the right ones, get them in the right order so that each patient sitting in the queue can be holding their personal record. And they've tried various things of having people with actual scheduled appointments and doing it the night before. Well, for one thing, they'd have to work till midnight. And another thing is the people don't always show up on the day of their appointment, and then everything's out of order. So, this is what people are actually coping with. So what are my larger conclusions? One, and I'm going to back up from this just a minute and say my big conclusion is that you shouldn't try to transform the lives of people you know nothing about. It's just hubris of the worst sort. We found all these things. Again, this is in a Fraud Embrace where people would write a proposal for, caring for poor people in Malawi, and we would look at the language and say, that looks familiar. And it turned out all the description of women would be directly plagiarized from the Aga Khan Foundation's description of women in India, where donors think all women are the same. Being poor means you are, backward. And I'm sure women in India aren't like this either, but African women certainly are not like this. And so there's this kind of stereotype that you understand global poverty. And if you understand it in one place, you understand it everywhere. And it's all the opposite of the wonderful way we are. we're fantastic. We're modern, we're individuals, we're empowered. Great. And I just think that it's a terrible mistake not to understand more about the motives and interests of local participants. I will say we're not the first people to notice this. The classic work on street level bureaucracy by Lipsky, papers like Kaler and Watkins on disobedient distributors make broadly similar points, but it just cannot be repeated enough that you cannot make global health policy for places you do not understand. And you can't understand them just by getting a few educated elites from those places to tell you all about their country. This is Sally Ingleberry's wonderful book on global violence, or whatever it's on gender violence. That's the book. She has a very, very good description of this exact problem. Okay, so I will now be bold to say, I really think we need something that I would call a new research ecology. And here my fantasy is the project we did was accidental, but the idea that global health policymakers should be in direct touch with small groups of people on the ground, actually studying how things work in real time, both before projects are designed and implemented and as they're ongoing. And this can't be M&E. I have studied M&E as a sociological thing. The people who get contracts to do M&E, it's just most of it, all right, I won't go too far, but a lot of it is not helpful. And my work is totally unhelpful. Why? But because by the time this paper is published, it will be years. Let's assume the paper, we actually have a full draft, and as soon as Laura has a break from medical school, we're going to work on it again, which is in a couple of weeks. She has to do well in her exams, yes. It will be published so long after the event. There's no chance that the circuit of influence could come back around. Joe was asking me, the ripples my book on AIDS policy might have made, and the answer was basically none. But even if it became a hot thing, and for other work I've done, I've got invited to talk at the World Bank and whatnot, but there's no real-time interaction between the people doing things. There's no real-time ability to autocorrect or to understand what's happening. And so I would instead see the big policymakers always being in touch with small groups of researchers in real time, so they could envision how their projects might be received, what might actually happen on the ground. And I would make, and this is my most fun suggestion, the opposite argument as well, which is people like me who are qualitative field workers, and I'm going to explain what this is in just a second, sometimes recognize that the qualitative stuff we're finding could actually be turned into policy if we could find quantitative researchers who would actually look at this problem on a large scale. So one of the recommendations we started to think of is, wait a minute, you've got all these people who have a high viral load, but some of them just have a tiny high viral load, and some, like my Patuma, have grotesquely high load at which if she had sex with anybody, she would almost certainly infect them. She's likely to die. I didn't mention that the friend, the guy who helped her, had a friend die. Just in that, they wouldn't stop giving him EAC, they wouldn't give him drugs, and he did die. So that is really a risk. And I started to think, couldn't you at least create something, a new acronym, VHVL, very high viral load, and give priority? Those would be the people who get the testing done. Those would be the samples they carefully shepherded back and forth. Then, preparing for this talk, I was fooling around with this one little document, and I blew up the column you see in front of you, and I realized, what is that next to male or female is how long they've been on antiretroviral drugs. And so let's go through 2 years, 6 months, 6 years, 8 months, 13 years, 12 years, 12 years, 2 years, 4 years, 4 years. Do you think that those people who've been on antiretroviral drugs for 6 years, let alone 12 years or 13 years, are not adhering, and that's why they're starting to get sick? No, they have almost certainly resistant virus. And so if you did a quantitative study and you tried to download all this information into a computer, and you could do it by sampling these registers from a large sample of clinics, and then and trust me, there are a billion Malawians who would love to do the hand transferring into a computer and would do it meticulously. They would not make a single mistake. You might be able to use the quantitative data to create profiles of 4 different likely kinds of people with high viral load. Those who are recently infected and were infected by a resistant virus from the get-go. Those who are taking their drugs irregularly, so they started out, healthy, but they never got with the program. Those who have been on meds so long and doing well on the meds that it is almost unimaginable that their problem is adherence, as with my friend, and so forth. And then I realized, these qualitative researchers could suggest research issues that they're not competent to do. They could really make a difference in policy. So I think if we thought about research, not just as I want to write my little article and get it published, I want to write my little article and get it published, but if the policy people would think about what kind of research ecology might generate constant interactions between the people who do large-scale studies of large populations and the people who have a sort of micro sense of what's happening on the ground, we might be able to generate much more productive use of academic understanding and research enterprises, and we might get better policy in the end. So thank you.